Good morning, everybody. Hello, and thank you so much for coming to this session, one of the first sessions of the Skoll World Forum. I want to guess that if you came here today, you've either already work in One Health or potentially came to find out what One Health was all about. So that's a good audience to have because there's expertise and curiosity, and those two make for good solutions. I say this because when I was telling friends, educated ones, what I was coming to do and what the panel was about, and often when I talk about One Health, I sort of, diplomatically phrase it and say, I presume you're familiar with the term One Health. Sort of nervous pause, and then I see a bit of a frown, and then I explain that it is the notion, the very intuitive notion really, that human, animal, plant and planetary health or environmental health are all deeply linked, inextricably linked. And before I even finish the sentence, there are nods of recognition. Oh, yes. In fact, they actually know what One Health is. Perhaps the term is the problem because the notion is incredibly intuitive. But there's a lot to explore about it. And for this, we're so thrilled to have experts from across the planet here today to really tell us how the pieces of the puzzle fit together, and with them and with your questions and with discussion, we'll explore how we can get that to more familiarity and particularly to policy, action and funding for that matter, so that One Health really becomes action, as the title suggests. So we will explore this story in a way that first takes us to the origin of One Health. Our first speaker will be Gladys Kalema, but before I introduce Gladys a bit in slightly more detail, just wanted to say that we have one speaker who'll be speaking in Portuguese, Luiz da Silva. So remember for that session to, if you're not Portuguese speaking, to switch to Portuguese. Thank you very much. So we will start with Gladys Kalema. It is a fabulous presentation she'll give us, and having seen it and having listened to her speak, at the end of her talk, we will know how human and wildlife health are so interlinked, it's almost impossible to separate them. She is with, it's on the board, but I'm just going to make sure that I get it exactly right. She's with Conservation Through Public Health, an NGO that of which she is a co-founder. Gladys, please come to the front, and we'd like you to take it from there and tell us your story of your origin story with One Health itself. Thank you.
Good morning, everybody. Excited to be here, the first talk of the conference. So it's great to see you all here. And thank you, Ida, for the wonderful introduction. I've been working with gorillas for 30 years, and my One Health journey began quite soon after I started working with gorillas as the first vet for the Uganda Wildlife Authority, and they hired me because tourism had begun, and they were concerned that people would make gorillas sick. A few years later, we founded Conservation Through Public Health, together with my husband, Lawrence, who's here with me today, and Stephen Rubanga, a vet technician who used to work for the Ministry of Agriculture. So you're probably wondering, what do people and gorillas have to do with each other? You get to find out in my talk. Because of our unique approach to conservation that's merging Uganda's wildlife management and rural public health programs to create common resources for people and animals, I was honored to become an Ashoka Fellow in 2007. And we've won other awards because of this, including being a National Geographic Explorer, winning the Whitley Gold Award, and being a Mulago Foundation Fellow, because they felt that what we could do is scalable. And I was pleased when UNEP Champion of the Earth finally saw that health is important for conservation. And I was given this award, and the year before they'd given it to another One Health champion, Dr. Fabian, and being seen as to win the Tauber Global Leadership Prize. And during the pandemic, I served on the WHO SEGO because they were concerned, obviously, that we're not sure whether COVID came from people or animals, and they needed vets to be on that committee. And I'm glad that BBC 100 Women recognized me among climate pioneers. And my journey began when I was told that the gorillas were losing hair and developing white scaly skin. So I contacted a human doctor friend of mine, and I said to her, what is the most common skin disease in people? And she said to me, it's scabies. Because at vet school, which I did here in UK, at the Royal Vet College, University of London, we were told that common things occur commonly. So if an animal gets sick, think of the most common thing. And it was a 10-hour journey from Kampala to Bwindi. So I got a bottle of ivermectin and a few other drugs, and we proceeded to Bwindi. And when we got there, the gorillas were scratching, and there were two vets who were in the tourists, happened to be tourists, and a senior vet from Kenya who happened to be around, Dr. Richard Koch. So he was able to give me a lot of support. And we treated the rest of the group, but sadly lost the baby gorilla. And on post-mortem, the body was still crawling with mites even after the baby had died of pneumonia. So we started to ask ourselves, where could this have come from? And we found out that there's a very hard edge between the community and the park, as you can see over there. And when it became a national park, people are not allowed in, but gorillas could come out. And once they lose their fear of people, they start to range in places they used to range before their forest habitat was cut. Because really, before tourism began, the forest was just disappearing, and tourism helped to save the forest and the wildlife. And people put out dirty clothing on scarecrows to chase away gorillas, baboons, and other wildlife. And they got in touch with the dirty clothing, and picked up the scabies, and it spread through the group. And obviously, people do it because the gorillas like to eat their banana plants, and this really upsets them. So it made me realize that you can't keep the gorillas healthy without improving the health of their human neighbors. And so very early on in my career, my conservation and One Health journey began. So in 2003, we founded Conservation Through Public Health to improve the health of people, to promote conservation by improving the health of people and wildlife together and enabling them to coexist. So we have 3 integrated programs: wildlife conservation with a focus on gorilla health and wildlife disease surveillance of other wildlife as well. And then community health with a One Health focus. So we look at diseases that can spread between people and gorillas and other wildlife, and also other issues that affect conservation and public health, which I found out, which I'll describe during my presentation. So One Health is more than just preventing zoonotic disease. There's also much more to it. I've discovered during this 23-year-old journey. And we added alternative livelihoods because we realized that many people are unhealthy because they're poor. So we started to support coffee farmers around the park by giving them a good price for good coffee so they don't have to enter the forest to poach. As I mentioned earlier in my talk, habitat loss is a big problem. And then we started to get into things like family planning. Because at the beginning, there was a whole USAID population health environment movement. And when they saw the work that we're doing, prevent this infectious disease, they wanted us to add family planning. And so whenever gorillas go into people's gardens, they're always likely to get sick and people get very upset. So it causes a lot of human-wildlife conflict. We carry out comparative disease investigations between the people, the wildlife, and livestock. We look at diseases that, not only the diseases in the gorillas, which are habituated, where we non-invasively collect samples every month from all habituated groups. Actually, when I started out, there were only 2 groups habituated for tourism. Now there are 28. So tourism has really grown, and that means that 60% of the gorillas in Bwindi are habituated for tourism, and they have to be followed every single day, in case also they end up getting poached if you don't follow them every day. And so this gives us an opportunity to find out what they have and what they could be picking up from people. And so over here, there is all the people who we work with to evaluate the impact of our community health program. We engage communities in conservation. So we have human-gorilla conflict teams who had gorillas back when they come out. They also collect samples. We work with the village health and conservation teams. They're actually village health teams or community health workers which teach to do conservation work. When we started out, the system hadn't reached Bwindi, but a few years later it reached, and then we just hired all the VHTs to become village health and conservation teams. Actually, they're volunteers, we don't hire them. but we give them incentives to keep them going. And they carry out a lot of behavior change communication using a shaming technique. So it's the bad family that does everything wrong, the good family that does everything right, and everyone wants to end up being the good family. We now have over 430, reaching over 50,000 people in 59 villages around the park. And they also give injections for family planning. And we sustain them with group livelihood projects. This is something that they requested for, and Stephen, our founder member, said, let it be a group activity which brings them together. And then when CARE was promoting village saving and loan associations, they put our logo on their passbook without asking our permission. But we were happy. It was a positive unintended outcome. And we're really happy that they're keeping on going, even in between donor-funded projects. Whoops. There's some of the One Health strategies which have led to policy change. We advocated to the Uganda government through our work, and they established a Uganda National Population Health Environment Network, which also went to East Africa. So I hope to write that policy, and there's an East African community PHE network. And then we also advocated, and now we have a national One Health platform, which is wonderful. This started in 2016. There was a student, Alison Haynes, who was at Oxford Brookes, just around the corner, and we asked her to interview tourists to see if they're willing to wear masks 10 years before the pandemic, and they started to say 51% said they were willing, and it kept growing. So I have to say that the One Health approach really came into maturity during the COVID-19 pandemic. We found that great ape viewing regulations had to be upgraded. Before the pandemic, you could visit the gorillas 7 meters away, you don't wear a mask. But we did studies and found that 98% of the time, people and gorillas got too close to each other. 60% of the time, people broke the rules. 40% of the time, it was the gorillas who broke the rules, because they were very curious. And so when the pandemic came along, everyone was now used to hearing social distancing, put on masks, hand hygiene. So we used that advantage to get all the tourists to follow the rules. And now it's mandatory, because even during the pandemic, they had less flu from people because people were not getting close. So we joined the National Ministry of Health COVID Task Force. We're the only conservation NGO who did. And we became essential workers. We were extremely busy during the pandemic because we were concerned about COVID in the people and COVID spreading to the gorillas. And so we trained our existing One Health groups, we had already set up, the VHCTs and Gorilla Guardians, in COVID-19 mitigation, which went really well. And they prevented mild cases from becoming severe cases, especially when the Delta variant came along. But we had another challenge, is that because tourism had disappeared overnight, people were hungry and poaching went up a lot. And that's when we realized that a lot of people are poaching because they're hungry. So we started to provide fast-growing seedlings to communities around Bwindi. And the first 1,000 households which we provided to, they did a questionnaire and they said people are poaching because they're hungry. So this poor gorilla was killed during the crisis by a hungry bushmeat poacher, Rafiki. He was called Rafiki because he's friendly, and he was the head silverback of one of the popular gorilla groups in southern Bwindi. And so this has become some of what we do all the time. And the poacher's wife, because he went to jail for 11 years, she was one of the first beneficiaries. She was 22 years old with 3 children under the age of 3. So we realized we really have to reach out to her. And now she stopped, she's able to have the children she can manage. She's not having any more children. But one thing we're very proud about is that when we started out, yes, we had been running for about 15 years, but you find that somebody has a hand washing station, but they don't have a clean toilet, or they're not drinking boiled water. And the Ministry of Health indicators are only looking at one thing. Oh yeah, hand washing stations have gone up from 30% to 60%. But we were seeing that homes were not really changing. So we decided to develop a model household approach where we're following 12 ideal indicators and we're getting everybody to adopt all of them. So if you have less than 4, you're red, and then orange, then green. And so we're pleased that over time, the green households grew from 23% to 65%. And we're pleased that the mountain gorilla population is continuing to increase. The census the last one has been done last year, and when the results come out, we hope to keep seeing an increase. Oops. And what's next? We want to expand our One Health model to the 10 countries in Africa that have gorillas. And we'd be happy to work with you, any of you here who are interested in expanding One Health across Africa. because we believe it can reverse the trend of the other gorilla populations whose numbers are going down all over Africa, apart from the mountain gorilla population in Uganda, Rwanda, and DRC. Thank you so much, and look forward to your questions. I wrote a book about my conservation journey, and the foreword was written by Dr. Jenguro, who was a mentor of mine, and yesterday I attended her memorial service here. And this book is available, I think, in the Inspiration Library at Skoll this week. Thank you very much.
Thank you so much, Gladys. I think that made that interconnectedness so clear. And I feel now we need to ask, how can we prevent this spread sooner? How can we do earlier detection? And here from Bangkok is Patipat Sumpao, who's with Open Dream. He is a health technologist, has always worked in finding technology solutions for public health problems, and he has worked specifically on this question: how can we detect the spread of disease from humans to animals and vice versa sooner? Thank you, Patipat.
Thank you very much. Sawadee, good morning. And my name is Patipat from Thailand. I'm based in Thailand, and my background is computer engineering and also public health. So I want to work on some fun and exciting intersection, which is health and engineering. So the projects that I'm going to talk about today there are two projects. One is called PODD and another one called POOP. And it's trying to stop the next pandemic before it starts. And we are trying to catch the signals at the source before it spread. And also, the project has been in the work for more than a decade now. So there are some data that I hope might interest the participants. So as you may know, the number varies. So, but from 60 to 70% of the known diseases and outbreak came from animals. And also, historically, the SARS, H5N1, likely also COVID-19 came from animals. So, and the contact points between human and animals were mostly, there is no lab around that contact point. There's only farmers, there are only herders. So we're trying to challenge ourselves. How can we detect the signals of the beginning of the outbreak or the sickness in animals before it starts spreading to humans? And that is exactly what we are trying to do. So the first one is called PODD. It stands for Participatory One Health Disease Detection. It's launched back in 2014. We work with local university in the northern of Thailand, and also work with the Department of Livestock, and also got support from Ending Pandemics, formerly called Skoll.org. So what we are trying to do, we try to bring each partner with a unique expertise. The university brings in scientific knowledge. The Department of Livestock brings in the authority. Ending Pandemic bring in funding. We bring in technology to try to work together. And so what we are trying to do is we don't try to train the farmers to be epidemiology. We just try to make them be able to spot the let's say the irregularities of health activities in their animal farms, so they can start sending information and engage with the actual actors. So the way it works is we build the system. It's like very simple app that the farmers can report. Just only 30 minutes of training that the farmer can start using the app. It's very simple. And back in 2014, only less than 50% of the farmers has an access to smartphone. So we need to do an additional training on how to use Facebook, how to use WhatsApp, so they can get familiar with the screen and start using the phone and taking picture. That's a very important part. And when they spot some, for example, drooling animals or sick chicken or dead pig, which is happen all the time in Southeast Asia, but it is mostly get ignored because the authority doesn't have eyes and ears on the ground. So we ask the farmers to capture those signals, and the app try to do auto routing. So if it looks very suspicious by doing a digital image processing and also the data analysis, if it looks very suspicious, we will try to forward to the expert to validate. If it's completely nonsense, for example, there was a report during New Year's Eve from the drunk farmer that they say, like, I love you all. It's true. So the system will automatically like don't forward to anywhere. And once the expert and computer make the decision, it will forward to the right actor in that area. So we engage with a local veterinarian, we engage with local government, so they can take actions instantly. So what we try to do is, so it still has, I would say, like limitation, because you still need a farmer. You still need someone with eyes and ears to see it. But what we're trying to build is we're not trying to create the new system. We're not trying to create a new culture. In Southeast Asia, it's more like the communal feeling that all the farmers are protecting each other. So if the farmers spot sick animals, we have to work with them that they overcome the fear that the authority will come in and cull all the animals. But it's about like helping each other. So we build that into the system, and most importantly, we build it very simple. So it's not a fancy technology. It's not make the farmer scared of using the system. So that's for PODD, participatory One Health disease detection. It's relied on humans to see the symptoms. So after that, starting from last year, we start thinking, how can we make it faster? How can we use another kind of data point to detect the signals before the symptom shows? So we're trying to experiment on the molecular layers. The PODD was about behavioral layers, so like people moving, people seeing, people hearing. But on this one, we're trying to do called POOP, Proactive One Health Outbreak Prevention. So we rely on the wastewater of animal farms. So there are during COVID there are some works that the people do wastewater testing to detect COVID before the symptom shows, and we want to try that in the farm settings, and so we work with the community, also with the community, and ask the farmer to collect, can I say it? P-O-O-P? Poops? Yeah, so collect animal poops, and then we work with the local laboratories to do genomic sequencing. And we built the technology to try to make sense of those data that came out from the sequencers. And the pilot is still underway, but the preliminary result shows some promising results that we probably could see the data that specific pathogen is floating around in the poops of the animals, and that can show the potential of using this new layer of data to prevent the outbreak or the sickness of the animal farms before it even shows the symptoms. So both PODD and POOP are trying to do the same thing. So we want to detect the sickness in the community level before it starts spreading, but with a little bit different angles. And one thing I just realized today, that when you have One Health in your project name, with the O you have vowel, and you can like play with many interesting abbreviations like PODD, POOP, and I think it's what we are trying to prove right now is if we can have PODD as the first layers of detection and move to poops for the confirmation layer, or vice versa, that can probably, hopefully, speed up the detection and response, and also prevent the next pandemic before it starts. And what we learn right now is three things. One is the governance. So in order to do this, we need to set up the governance that everyone knows what to do and who to move. And also the finance needs to ingrain into the local government, so the local government can do their own budgets. And also the scalability using technology, so it can scale up from one community to another faster. And yeah, the next pandemic is likely to come from animals again. Hopefully COVID-30 is not coming if we work together using One Health methodology, and hopefully that this can show you some of the potential of our works. Thank you very much.
Thank you so much, Patipat. I mean, just amazing how much additional knowledge is being generated by involving people who would be most affected at some point. And I think that raises the question about the ancient knowledge of people that has actually always been there. And this is what Luiz da Silva will talk to us about. He is with the Amazon conservation team and works very closely with indigenous communities who have, of course, always understood that humans and their environment have to live in balance. Thank you so much. And remember about headsets if you do not follow Portuguese like me. Thank you to the Portuguese speakers. I think there are quite a few for being here. That's wonderful.
Olá, bom dia. Ah, bom dia, que bom. Para agradecer ao Fórum Skoll por proporcionar essa possibilidade de podermos falar em português, porque isso, no nosso trabalho de mais de 30 anos, é um grande desafio, porque só no Brasil a ACT trabalha com 32 povos, 32 línguas, 32 idiomas, 32 culturas diferentes. E é importante compartilhar com vocês. E agradecer o Mark, que está aqui, Lili, são fundadores da ACT, e também a Dirk, que está na nossa equipe. Uma coisa importante, e também agradecer já a Gladys, o Pat, por introduzir o tema de uma só saúde, porque é um conceito, é um tema, uma discussão muito importante, muito atual, que conecta saúde, conecta tecnologia, conecta conservação, e é por aí que a Amazon Conservation entra no tema de uma só saúde. E é muito importante porque a nossa concepção, enquanto organização que quer contribuir com a conservação do planeta, surge e nasce exatamente da observação de que não existe saúde, não existe conservação, não pode existir biodiversidade se essa conexão ela não está amplamente formulada. Então, nós aprendemos isso de um chamado dos povos indígenas, e quando eu estiver falando povos indígenas aqui, podem compreender como a diversidade, né, dos quilombolas na Colômbia, dos povos que estão nas tabancas de África. Esse é um pouco do conceito que nós trabalhamos. No Brasil, são 72 comunidades tradicionais diferentes. Então, nós nascemos desse chamado, né, que tem uma conexão com os humanos e não humanos, os gorilas, Gladys, a biodiversidade, a proteção da biodiversidade, a diversidade que existe e a resiliência climática. Então, essa contribuição que a ACT quer trabalhar nessa perspectiva de conservação nesses 30 anos foi nos possibilitando compreender de que nós não estávamos tratando, quando existia necessidade de proteção de um território, de doenças que existiam, ou mesmo de dificuldades espirituais, se tratava de algo da necessidade de que nós precisávamos fortalecer os sistemas existentes nos territórios. E que sistemas são esses, né? Vocês devem estar se perguntando. Eles nos ensinam e nós compreendemos que os povos, né, nós, povos, os não humanos, os povos humanos, a relação com os territórios e a espiritualidade se conectam em algo que é complementar, né? E isso nessa foto, né, vocês podem ver nessa foto, é o povo Tirió, né, numa região extremo norte do Brasil, em que alunos, né, de formação em medicinas indígenas estão trabalhando com seus xamãs. Então, são alunos, jovens, o território e a análise dos humanos e os não humanos, né? A nossa perspectiva, então, enquanto organização, não é de criar, proporcionar novos modelos, mas sim de relacionar, né, dinamizar o que existe, né, de conhecimento ancestral, de desenvolvimento de práticas que são milenares e relacionar isso com aquilo que a tecnologia, né, os conhecimentos adicionais que estão possíveis e à disposição para contribuir e fortalecer esse nosso trabalho. Ou seja, é conectar o conhecimento ancestral com as práticas e os conhecimentos que existem hoje. Nós temos, como falei, 30 anos de trabalho, né? Nós nos conectamos, promovemos, contribuímos, atualmente com 402 povos e territórios diferentes na Amazônia, Costa Rica, uma parte do México, nas Guianas. Mas nós escolhemos trazer, né, para compartilhar 3 experiências que estão no território da Amazônia, que inclusive está na nossa missão e está no nosso nome enquanto organização. Uma primeira no escudo das Guianas, onde comunidades, já há mais de 20 anos, elas monitoram seu território, né? E aí, qual o nosso papel? Contribuir e fortalecer para que a forma tradicional de monitoramento possa conseguir se atualizar para os desafios do momento. Há 200, 300, 400 anos atrás, essa estratégia de monitoramento desses povos não tinha a tecnologia que hoje os garimpeiros, os que vão desmatar os territórios, as novas doenças que surgem. Então, a estratégia é fazer com que o processo de monitoramento que eles fazem consiga ser mais eficaz, GPS, drone, e a partir desse processo de monitoramento e também de proteção dos territórios, eles consigam, inclusive, planejar de forma a caça, a pesca, a produção de mel, de óleos, inclusive se antecipar a doenças que anteriormente não existiam. Isso é uma estratégia que trabalha com vários povos quilombolas e guianas, com povos indígenas, os tiriós e outros. E é um trabalho que cada vez mais se amplia. Mesmo no Suriname, por exemplo, ainda não existe uma legislação que reconheça os territórios dos povos indígenas e tradicionais. Isso é um desafio imenso. No Brasil, essa é uma estratégia, também uma estratégia que nós desenvolvemos. Essa fotografia é uma fotografia de um centro que foi construído através de um pedido deles, que eles observavam que os especialistas em plantas medicinais, as mulheres que desenvolviam os partos nas comunidades e mesmo os xamãs estavam cada vez mais diminuindo a presença. E eles nos buscaram para que a gente conseguisse, dentro da tecnologia, dentro da arquitetura deles, ampliar a possibilidade para que pudessem desenvolver e conectar. Na Colômbia, todo esse trabalho, que muitas vezes se conecta com o que estava em Guianas, com o que estava em Brasil, também tem se constituído em possibilidade de políticas públicas, né? Seja na integração entre a proteção das plantas, a integração climática, o monitoramento biocultural, muito importante. Isso é uma tecnologia que eles nos ensinaram e nós estamos devolvendo com novas ferramentas da atualidade para que eles consigam e ampliem, inclusive para detecção de mercúrio, que polui os rios, os peixes e diminui a quantidade de alimentação. Vou correr que já está bem no final. Então, para nós, um ano só saúde é a integração fundamental da governança dos povos indígenas, do seu território, a integração territorial e, principalmente, uma perspectiva de adaptação contínua aos desafios que estão lá. Essa é uma fotografia fantástica, esse é o cacique Capai de lá do território brasileiro. Eu vou pular esse e passar para um próximo, que é um pouco da contribuição que nós queremos enquanto organização, que é o nosso papel não é substituir, nós não queremos, né, não é essa nossa missão, mas é ampliar a possibilidade de visibilidade dessas estratégias, dessas formas esses sistemas de uma só saúde, de proteção, de conexão e de vida. Cada vez mais possibilitar que essas estratégias possam se constituir como alternativas de saúde e de convivência, e em especial de conservação. E, por último, também trazer e fazer com que a ocupação dos territórios tradicionais seja parte das soluções. Isso é o grande desafio que os povos indígenas de todo o mundo falaram na COP30. a nosso modo de vida ele pode ser uma alternativa às mudanças climáticas, né? A conservação dos territórios, a demarcação dos territórios é parte das alternativas climáticas. Isso é um pouco daquilo que nós trabalhamos com alegria sempre, né? Com festa e com boa comida. Muito obrigado, mais uma vez.
Thank you. Thank you so much, Luiz. That gives us a broader way of understanding the interaction between humans and their environment. But that understanding so seldom, or up to date, has seldom translated into formal policy adoption. One hears here and there of countries which have a solid One Health policy. More are adopting this now, but not yet sort of tracking it properly. And this is the area where Toni works. Thank you so much, Toni, for joining us. Oluwatoni Akinola is with DRASA Health Trust. She joins us to tell us about how to bring all of this together to ensure that policymakers buy in, understand it, and also that those who support policymakers support this approach. It's a tall order, and she's already achieved a lot of success. So thank you so much, Toni.
All right. Good morning, everyone. Thank you so much to the speakers for doing justice to such an important topic. So my name is Oluwatoni Akinola, and I'm a program manager at Dr. Ameyo, Stella, Adadevoh Health Trust. So I'll start here. Before I go into our work and some lessons I'd like to share, I'll start with a moment that shaped DRASA's DNA, because it's a lesson in One Health thinking, even though we didn't know it then. So in 2014, Dr. Ameyo, Stella, Adadevoh made the courageous clinical decision that honestly prevented a national catastrophe in Nigeria. Even though she hadn't seen or diagnosed Ebola before, she correctly suspected and confirmed the first case of Ebola in Nigeria in a diplomat arriving from Liberia. So her courageous decision stopped the spread of the deadly virus across Africa's most populous country. So just to give you a picture of how disastrous it could have been if it spread. And under immense pressure, she chose containment over convenience, and her actions stopped Ebola in its tracks. Unfortunately, she lost her life in the process, and some of her colleagues too. So DRASA Health Trust were founded to turn her legacy into a system of everyday prevention, making sure that your everyday person, from your teacher to student to local butcher, farmer, has the capacity and understanding of infectious diseases to be able to prevent it. So I'm going to share 3 practical lessons from our work at DRASA, from our experiences in operationalizing One Health. And it's through community systems, through public governance as well. And I'll share it using antimicrobial resistance as a test case. So not assuming we all know what AMR is, I'll just share what it is. So it is a One Health problem that we're solving. And it happens when the antimicrobials, so your antivirals, antifungals, antibiotics no longer work. So we're used to just having them as a resort when there are simple surgeries done, when there's chemotherapy. So in the instance of an infection, that's our quick go-to. But the challenge now, the global challenge, is that there's antimicrobial resistance, right? In a study done by IHME, we have the statistics that there's a projection of 39 million deaths due to antimicrobial resistance between 2025 to 2050. And that's a stark reality of approximately 3 deaths per minute. And it's a One Health issue that we're solving because it's caused by the contributing factors of human health, animal, and environment. So misuse and overuse of antimicrobials in humans, in animals, in food systems, as well as its reinforcement in waste and environmental contamination. So I'll just share those 3 lessons that I talked about. it's important to start with the communities, and that's the work that we continue to do at DRASA. It's important that the health solutions that we say we are coming up with target those that it affects the most. And it's important for communities to be co-producers of health, not simply beneficiaries. And I'll just share a short story that captures this. So in a peri-urban community in Nigeria, we have Aisha, who is a traditional birth attendant, and she's been trained by DRASA to become a health champion. We've equipped her with the knowledge that she needs to just see disease trends and be able to escalate it to local health authorities. So in her community, she sees that there's been some persistence of stomach illnesses in some families, and she hears reports of poultry deaths as well as an informal slaughter points near water channels. And an everyday person may not know that there's actually a connection, but because of the training and the mindset change that she has received, she's able to escalate these patterns to the local authorities and help them also work with the community leaders to change hygiene practices, change water use practices as well. And so that's the model that we're using at DRASA, building a network of health champions. So you're an everyday person that's equipped with the knowledge and they know how to prevent diseases, how to work with the local leaders to be able to influence change and curb diseases. So at the moment, we've equipped over 96,000 health champions across Nigeria and counting. We're still working on it. We're still scaling. Lesson 2 is design for cross-sector coordination. So you've heard already One Health, animal, human, and environmental health, it's all connected. In Nigeria, and I'm sure some other contexts as well that you may represent, we have the ministries of health, agriculture, environment. They're different ministries, they have different budgets, they have different plans, and also different incentives, right? And we have all these policies, but how do you actually get it into implementation? There's usually that implementation gap, and so there's breakdown at the point of delivery. And so at DRASA, we've been working with stakeholders across board, so health, animal, environmental sectors, youth, civil society organizations, media as well, because we need that full system view of the work we're doing. And a great example to use of how we've been doing that, working with these sectors, is the development of the National Action Plan for AMR, antimicrobial resistance. So we worked with those ministries, animal, human, and environmental health, One Health agencies, development partners, the World Health Organization, United Nations Environment Program, to develop a 5-year costed strategy, a One Health focused strategy. And so this is our second action plan developed. So the first, it was great, but it had some limited impact because it was very human health focused. So we saw that that was a weakness, and we made sure to integrate One Health in the development of the second plan. So we worked with over 140 stakeholders for a 27-month consultative process to develop a national action plan that represents the different sectors. And the takeaway from this is that you can't just have a multi-sector committee and call it integration. It has to actually work in practice. So you need a shared problem definition. What is it that we're working on? What is it that we're responsible for solving? What is our shared data system? What's our shared data set? What are we tracking? How are we following up? How are we monitoring and evaluating? And also a joint operating plan. So what is it that we're saying we're doing? Okay, we have a policy. How often do we meet to make sure that we're on track? That is how we have One Health across sectors in practice. And lesson 3, the final one, is begin with the end in mind. So at DRASA, we're making sure that we don't have to be in the picture for the full scope of things, right? How can the work continue without us? And that means that prevention is at the heart of what we do, and we have to consider these 3 things. So we're building local capacity and ownership. We are aligning with existing government mandates. So we're not just doing something that is out of alignment with what the government actually has as a policy. And we're designing the handover from day one in our health solutions. Pardon me. Okay, so I want to leave us with a question, but before I do that, just to share that we continue to focus on the community model that we have. We're continuing to scale the building of health champions in Nigeria, And with the support we have now, the partnerships and additional support, we'll continue to scale it up so that we have that community surveillance, we have deepened coordination across sectors, and we're able to just be able to have the work continue without us. And I want to leave us with this question. So are we able to reflect One Health in financing, in governance, and also in delivery? That's something that we need to consider. That's something that we need to have as the focus. So thank you very much for listening, and this is how you can stay in touch with our work. Thank you.
Thank you so much, Tony, for that. So all speakers will come to the front now, and we will explore some of the tensions of what they've highlighted for us. Just to let you know, there will, of course, be opportunity for questions from all of you, which we are really looking forward to. So we will just have a short discussion now. Thank you. I want to kick off by asking all of you and any of you to respond. Is what are some of the tensions that you've described? You've described them just now, Tony, and that you have seen that have been unable to be resolved. And have there been tensions between various government departments or people not quite accepting your approaches that have been well resolved? So 2 questions. Is there a positive story, a negative story that you can tell us about and which we could learn from anyone? You have an AMR plan, right? Oops.
Okay. So I was thinking about how best to frame. Can you go with the question again?
Yes. The question is, Tony, you've highlighted that there are tensions sometimes in this integration story. It often happens, isn't it? When some integration sounds like peacefulness, sounds like solutions, but of course it often means that people have to give up their positions. Positions of power, positions of ideology even, etc. So it's fantastic that Nigeria now has a an AMR plan. That's a success story. Can you tell us a little more about how you got to that? Yeah. And I'd like to ask you or anyone else, the second question is, are there intractable tensions that you observe in your surroundings that still need to be resolved?
Okay. Thank you so much for the question. Okay, so in my presentation as well, I just alluded to the fact that it was a long process of the development of the plan. So 27 months of a consultative process with the key stakeholders involved in One Health in Nigeria, in AMR in Nigeria. And I would say the tensions come in making sure that everyone's voice is heard and contributes to the development of the plan, making sure that no one is left behind, because we can sometimes be very human health focused, but how are we drawing in the environmental perspective of AMR and how to solve the issues, how to treat the issues? So I would say the tension is in making sure that everyone is involved and not leaving people behind, and ensuring that the plan is costed. So we don't just have a plan that doesn't have the financial backing. We don't just have a plan that doesn't have a monitoring and evaluation framework. So it wasn't an easy process, but it's been done. And we continue to just make sure that we are working to implement, working to track what it is that we're doing and seeing the successes, learning from the weaknesses as well in implementation.
Yeah, Gladys, please go. I can see you have something.
Just add on to what you've just said. Whenever we have like outbreaks like Ebola or anthrax or things like that, especially Ebola, there's so much, everybody gets together. There's now National One Health task forces, and everybody rushes to deal with the people who are dying and to prevent further people dying, more people dying, and everybody forgets where could the source have come from. So by the time everybody comes around to finding out actually where could it have come from, the evidence has disappeared. And by that time, if somebody ate a monkey, they won't say it because now there's so much stigma. And let's say a family died, they won't talk about it. And then you're not able to find out how it happened. And so it's so important that equal resources are put into preventing cases, the medical side as there is to the ecological side and the animal side. So I think there's always that.
Right.
panic. And the same thing happened in the COVID pandemic, actually.
Definitely.
Yeah.
I mean, to this day, I mean, people have there seem to be strong camps about where COVID came from, as we've seen. I'd like to explore that a little bit more with you. I mean, why do you think it is that people are quite so obsessed with where it came from? You know, with Ebola, we saw that with COVID, as you've said, even in our homes. Why does my child have flu? You know, we don't have flu here. So there's a sort of almost a kind of a real persistence often that people have to say, what is the origin? Where does it come from? Why do you think that is?
I think it's really important because you want to prevent it happening again. And I think that's why people really want to know where it came from. And sometimes they're in denial, you know, about where it came from. So, for example, in Congo-Brazzaville, they've had a number of Ebola outbreaks. And they've had them in the great apes, you know, the chimpanzees and gorillas have died of Ebola, and people who ate them died of Ebola. But a lot of people thought it was witchcraft. So I happened to be there actually when my husband was doing some work there with Ericsson. And because of our One Health work in Uganda, also working with traditional healers, just like you do, they wanted us to talk to them to see how they can engage traditional healers. Because they're the ones who tell people, don't touch your loved one, because a whole family would die because they touched this loved one and they think they were bewitched. And so people always want to know, and they're always in denial about what the real thing could be. And when they created the WHO Scientific Advisory Group for Origin of Novel Pathogens, Dr. Tedros said to us, we just want to know, you know, we want you to look at all the studies that have been done on COVID and help to advise on further studies because we want to know the source so we can prevent it happening again. Of course, part of it was also to set up a framework to prevent further pandemics, but everybody just wants to know what the source is so we can prevent it. But unfortunately, when there's this panic, everybody forgets to put resources into the ecological and animal side, and they just focus on the human side. Yeah.
That's really interesting. I mean, touching your loved ones is such a human instinct, isn't it? And it can be a very, very intricate and important part of tradition and culture. So, Luiz, that makes me wonder about the work that you do and how you balance the obvious strength of indigenous knowledge and new insights that have in the meantime come through further studies, through other scientific exploration. How do you balance those two areas of knowledge?
Antes de responder rapidamente, eu vou pegar dois grandes desafios. Um primeiro é que para os povos indígenas, eles não tratam da doença. A base de vida é com a saúde. Então, se a preocupação é com o equilíbrio do corpo, do território, do planeta, todo o conhecimento se volta para manter esse equilíbrio. E isso é algo que é fenomenal, né? E o grande desafio é conseguir fazer com que a sociedade e as políticas públicas, os governos, compreendam que isso é possível, né? Compreendam que isso é possível. Somente agora, dia 6, tem pouco mais de uma semana que o Brasil estabeleceu uma primeira lei que reconhece os especialistas em medicina indígena como parte de um sistema de proteção e de saúde. Então, no Suriname há pouco tempo também, na Colômbia recentemente. E um outro grande desafio é que não existe conhecimento ancestral se não existe território. Então, é outro desafio, como relacionar essa perspectiva da proteção dos territórios com a relação da saúde. E por fim, a sua pergunta aí, muito, muito interessante, é que a gente tem se desafiado a, primeiro, ser bastante orelha, né, Lili? Ser bastante orelha. A nossa organização é uma organização de mais orelha do que boca, né? Então, escutamos, aprendemos e buscamos os especialistas em tecnologias, em alternativas para que nos ajudem a relacionar a tecnologia com as possibilidades e os conhecimentos que existem. Isso tem conseguido dar muito certo, né? Tecnologias que ampliam a possibilidade de proteção e de monitoramento desses territórios e também da proteção da saúde. Esse centro é um exemplo disso. Tem tecnologia super avançada com a arquitetura dos povos Tirió. Isso tem conseguido garantir a ancestralidade deles com possibilidade de outras tecnologias.
Thank you very much. Thank you. Patipat, with this listening, the big listening that you are doing by having farmers contribute to the knowledge system, is there ever a danger that the information is too binary or too messy? Since you said we're not training them to be epidemiologists, is there ever a danger of over-alarmist thinking? Has that ever come up? And if so, how would that be resolved?
Yeah. Thank you very much for the question. That was the first question we got at the first meeting back in 2013. Like, how can we prevent the fake news at the time? That kind of thing. I would say yes. We worry about that. But what we worry the most was we worry about no one would say anything at all, even the fake news. We worry about the silence. We worry about the community got sick without people knowing, which has been happening before we start doing the works. I can give you some examples, very sad. In one community in very rural mountainous area in the northern of Thailand, there has been a repeated outbreak of the foot and mouth disease in cattle for decades, and the community thought that this is like normal way of life, and no one knows until we start doing the work in that area. And normally, averagely in at least in the northern part of Thailand, when something happen, it takes at least a month until someone knows what happened outside the community, and it took next to forever to resolve those issues. What we're trying to do, we create a big ears, we create a big eyes, big foot walking everywhere on the motorcycle. In Southeast Asia, we travel on the motorcycle. Some place they do ride the elephant. But what we do, we're trying to speed up the detection time from months to 22 hours using the tools that we're building. And also the response times for next to forever to at maximum 1 week. So that helps us a lot, and it makes us less worry about the fake information. It makes us less worry about the messy information. Any kind of information, just send to the system, and someone will help take a look at it. We have human in the loop. We also like work with, as I mentioned, local universities. So they have their own staffs to take a look at the data. Obviously, there will be some Happy New Year. There will be some I love you. But that's nice. Like at least someone talk to you, right? But like what we would worry is like no information at all. Mm-hmm. Yeah.
That's amazing. Talking about information, I really can't help asking you about fake news information, and COVID is still really fresh in our memories. I mean, at the time there wasn't such a detection system in the Wuhan market, and as a result, all of the post-COVID investigations caused both controversy and massive insights. If you were to imagine a disease outbreak outside of an area where you work, so not where the farmers are, somewhere in the world, not in the Amazon, not where you are right now, what from the work that you've done, what knowledge, what insights could you contribute to this community or the country or the district, town, village, wherever a next pandemic might break out? What contribution can you give?
Okay, so incredible question, and it makes me think communication. So I think from our learnings from the different outbreaks that we've had, Nigeria faces concurrent outbreaks annually, which we continue to respond to, but I mean, there's still occurrences. And communication is one thing that is extremely critical. And it's important to make sure that the information about diseases is in the language that people understand. So sometimes we get very caught up in the fact that we know the public health terms, and we know it amongst ourselves, but how can we get it down to the person that does not, cannot comprehend, the complexities of what it is we're describing. So working with the media is incredibly important to convey the information, working to ensure that it goes through the channels that people understand, through community leaders, through radio jingles, just translating it in a way people understand. And an initiative I'll share that we are currently working on is the Say AMR Language Hackathon. So we have over 700 languages in Nigeria, although we have the main 3. So we're working on how do we translate antimicrobial resistance to languages people understand. So to Hausa, to Igbo, Pidgin English, and Yoruba. And we're doing that using the youth across Nigeria. So we put out a call for applications for them to work in universities, in teams, in a multidisciplinary way. So not just public health students, students studying languages as well as environmental subjects and animal-related subjects. So working together in teams to develop a terminology for AMR in those languages. So of course, using their creativity, it's an innovative way of getting those terms we need to get it down to the last mile. So who's the person in the most rural area that doesn't understand English, but if you catch them in their local dialects, their eyes will even light up like, oh, you can say AMR in a way that connects with me. So that's something that's important, communicating the disease risk, communicating how to prevent the disease. So the person that doesn't understand what we may be saying here, they're able to protect their health and their family's health as well.
Thank you. What strikes me about what all of you have said is that it's people who are not necessarily scientists and people who are not politicians who are picking up a change in their behavior, whether they're wearing masks, willing to wear masks. 10 years before COVID, when we had people who were not willing to wear masks, for example, farmers contributing so much to the knowledge base, the indigenous knowledge system that has taught us so much over so many centuries, really now being recognized, and the work that you've just mentioned. But what about that big elephant in the room, government? How does one get their behavior to change? So the AMR health plan, the One Health platform that you've mentioned are there. But could you tell us a little bit about, what specific strategy would ensure that countries around the world and then globally and also regionally, that all of this would be recognized into one system? Anyone?
Esse foi um dos grandes chamados da COP30, né? Na COP30 em Belém, o que as organizações de todo o planeta chamavam os governos era para reconhecer primeiro, compreender as causas da crise climática global e, a partir desse reconhecimento, estabelecer estratégias políticas em cada país e globalmente de possibilitar que essas alternativas consigam se adentrar em políticas públicas em cada um dos países. Isso está afirmado ao final da COP. mas até se constituir em ações concretas em cada um dos estados-nações é um desafio grande. Vou dar o exemplo do Brasil, onde estou vivendo com proximidade. Desde 88, né, a Constituição brasileira determinou que em 5 anos todos os territórios indígenas quilombolas tinham que estar demarcados. Até hoje temos 30% dos territórios que foram demarcados. Mas isso era um compromisso constitucional de 88. Então, acho que tem um vácuo entre o que é firmado e o que é constituído enquanto ação. Então, resta à sociedade civil, à filantropia mundial, financiar, né, e apoiar ações como essas, não só como projetos pontuais, mas como estratégias territoriais e regionais que possam impactar positivamente a ação dos governos, né? Em Nigéria, em África, também em Tailândia ou na América Latina. Então, acho que isso é uma ação que acho que é importante.
Yeah, because it can't stop at the borders of one country, even if a single country adopts those policies. Thank you so much, everybody, and we'd all really love to hear your questions, and inviting you to ask questions to the various panelists now. Thank you.
So a quick one, this is general. I'm more worried about sustainability. For some reason, you knew that we need to work from a One Health perspective. But our governments and how we've been operating, especially civil society, it's either you're dealing with human beings, you're dealing with animals, or you're dealing with environment. We've been segregated. But now we're being asked to integrate. And we don't know how that is going to happen. Because even when donor funding comes in, it's either one or the other. So I was wondering, how do you sustain or how do you maintain that One Health? Because you're doing an amazing job, but funding usually comes in 3 different, baskets. And then the other issue, which I think DRASA would respond to, is how are you using community systems? For example, when it came to COVID-19, we found out that the government could not know who was sick, but the local chief already had information that that person died because they were coughing, and the other family is sick. So how do you integrate that community system that works quite well? So we've seen the power of communities, but my question goes back to funding. How are you maintaining a One Health? I know the WHO is asking us to now look at health from a One Health perspective, but communities, it's either I'm an animal, or I'm a human being, or I deal with the environment. Thank you.
Yeah, that is one thing.
Those are great questions, thank you. The funding is actually a tough one. And actually, when we started out, it was very hard for us to get funding because the human health donors would say we don't fund animals, including Bill and Melinda Gates. But now they've changed. Now they include One Health. And then the conservation people are like, we don't fund public health. So it was difficult. But then we finally found those donors who saw the link, like the MacArthur Foundation, the Irish government early on. And then we found there was a lot of, even some donors, which I won't say, they sent out a call for proposals. It's a conservation donor. And when we said, we have to look at the health of the people, they're like, this is nonsense. They actually gave feedback. This is absurd. And someone said to me, don't give up, try again. The next year we applied. They're like, oh, okay, you need to improve the log frame. The next year they gave us the funding. And then they said, health can also be considered. So sometimes it's about educating the donors, not giving up. You just keep educating them. And then now it's become, everyone's now thinking, we need to include, we can't just focus on health alone or conservation alone. It's actually good to look at how they can help each other. So I think there's a lot of donor education, and I think the Skoll.org Forum is a perfect opportunity to do this. Mm-hmm. And I hope after our session, there will be more funding for One Health. And then regarding, I think you asked a question about the communities. Actually, we found that the easiest people to work with was community and government. Why? Because they face One Health every day. A community doesn't choose a day for their cow to get sick, a day for their child to get sick, a day for their crops to get wiped out by floods. They don't have separate days for that. It happens to them all the time. And so when we come to them, one day they say, oh, you can't dig in the garden today, the health worker's coming. Or you can't dig in the garden tomorrow, the conservation person is coming to talk to you about the problems of dangers of poaching or cutting trees. Like that. They would rather you all come together and talk to them at once because they're facing this situation all the time at the same time. So I think with the communities, it's been really easy to work with them and having them to be we're using community-led conservation, community-led One Health. They've been the easiest to work with. They're real champions for us out there. And the government is the same. They actually realize that as much as they're siloed, they find that everything happens at once. So it's an efficient way for them to reach communities. And whenever we meet with our volunteers or training people, community volunteers, VHTs, village health teams, village health and conservation teams, we bring the health people, the vet people, the conservation people, the government people, they all talk to them, and everybody's working much better together.
That's great. Yes, please.
Hi, thank you very much. We talked about segregated funding, but I would love to talk about data systems. Tony, you mentioned it really quickly. I work in Madagascar. One Health is a priority there. Very vulnerable to climate, a unique ecosystem, and a number of health challenges. We've been working with Ministry of Health, Agriculture, and Environment on a One Health platform, but it has been so complicated because the data systems themselves are siloed. There has been much lower investments in tech, data, let's say for the Ministry of the Environment, and they're concerned, as they should be, about protecting critical data, endangered species. What's your experience in kind of overcoming those siloed data systems and any kind of lessons learned or success stories that you've had to kind of share with us on what does a shared data system for One Health look like? Thank you.
Can I go ahead?
Please do.
Okay, thank you. So I'll just answer your question that was directed at DRASA first. But before that, just to corroborate with Dr. Gladys, what she said about educating donors. So I think it's important for us to know what we're doing in country first and ensure that we are integrating our systems together. So it's like making sure One Health is on the table, animal health, human, environment. How can we make sure that the solutions we're coming up with internally before we are applying for funding, how can we make sure that we know what it is we are putting out first, and then letting donors know, like, this is the way we're working, so you can fit into that framework, rather than keeping up with the separation and then, applying for those segregated things. And on the community health focus and community leaders identifying outbreaks. So just to share a bit of our perspective of our community model, we make sure that when we're working in communities, we advocate to the community leaders, to the state ministries of health, agriculture, and environment in the particular states we're working with. So Nigeria has a state system, right? So we make sure that we're not just going into communities telling them what to do, what already exists, how do they communicate, if there's an outbreak, how does it cascade to the community leaders? So we help them and link them up with health facilities so they can communicate that data to them and let the health facilities know this is the data to collect. And there's just that working system of communication from the state level to the national level for the data to be pooled. And then on the question about data systems and integration, I totally agree, it's not an easy thing. We've been siloed for so long, so it will take a while to overcome the segregation in data systems. But I can say from our national perspective, so the Nigeria Center for Disease Control and Prevention, our national CDC, has continued to work to have an integrated way of collecting data. So it hasn't been without challenges, and I know it's still in process, so I can't even give full detail on it, but just to say for antimicrobial resistance particularly, we have what is called AMRIS, so our integrated system, and it's supposed to have the collection of data from agriculture, human, environment, plant health, and it needs you need the right indicators. You need an agreed framework of indicators to collect the data. So it will take meeting together. It will take going over what is already on ground, speaking over what needs to be done, what are we missing out, having that full system view from those respective sectors. And it's a process, but eventually, I guess, if we all have our hands on the table, then it will work.
That's really great to hear. Thank you.
Hi, my name is Alicia London from Prospera Global. I am excited to be here because I've come from a slightly different field, and as we talk about integrate, I just wanted to share a resource, particularly as we're talking about how we educate funders. We are funded by Wellcome, releasing a piece of research in a couple of weeks. If anyone wants a copy, I've got an early access here on how do you integrate into financing strategies. And one particular area that I think is really important, and we haven't talked about much today because it's often missed historically from the equation, which is specifically around mental health and well-being. So when we look at health systems, historically mental health has been massively neglected, and we're catching up. Less than 2% of a health budget when it's a 20% disease burden. When I started in mental health, I ran the mental health campaign for the Duke and Duchess in Cambridge and Prince Harry here, and then started United for Global Mental Health. That was only a few years ago, and there were 2 funders, very small funders, thinking about this. So as a system, integrating mental health into healthcare systems is one thing we're catching up on. And then actually, how does mental health integrate into achieving outcomes across climate? So we have funder briefs around how it integrates into climate, but also education and women's health. So, and I guess the message is this, the research that we're releasing really for the first time have pulled together that case. And what we find is when you invest in mental health and well-being of the people that are at the intersection of all these challenges, it's one of the best investments we can make, actually, that cuts across and has multiples of impact across them. So we often talk about things being neglected, we need to do more. The good news here is this is actually something when we invest in people that are at the forefront of multiple challenges. I don't think we've yet seen, well, we have many case studies of how this can transform people's lives and have that cutting impact across a lot of the climate and conservation and adaptation issues that are out there as well. So if anyone wants a copy of that research, we created it as a kind of really first way of making that case and how to do it as a practical guide for funders, and we hope it might be helpful for those that care about this intersection piece within that broader integration agenda too.
Thank you. Any response to that before we go to your question? No? Great. Let's go.
Hi, I'm Mark Wilson. I'm the Executive Director of Healthcare Without Harm Europe, and a big part of our work is fighting against antimicrobial resistance. So a question for Patipat and Tony. The big drivers in the developed world and middle-income countries, particularly India, is 2 things against antimicrobial resistance. One massive overprescription of antibiotics within the health systems, which is just completely out of control. And secondly, in developed world economies, agricultural farmers, 70% of antibiotics are used for animal husbandry. Is that emerging in middle, low-income countries? And how do we engage policymakers, and how do we really drive this at that level? It's beginning to emerge, as you all know, in terms of WHO and commitments, but on the ground change, particularly in Asia, is really problematic, and I fear that Africa may be going the same way too in both of those dimensions. What's your view on that, and how might we combat it?
Thank you very much for the question. I think from my work, in Southeast Asia. There are three parties. The community themselves still need some work about the awareness of AMR. As my part as a private sector / civic tech and society, we need Tony help on the communication, like why it's important. And yes, the government is still trying to do something about that, but it's still like moving slowly. But besides that, on the civic technology and civic organization like us, we just last month we trying to set up the network across the organizations in Southeast Asia to how can we bridge AMR surveillance, let's say, with the community groundwork, and how can we help them understand the importance of using AMR, not using AMR, because like currently from the farmer's perspective, antimicrobial resistant, the medicine from the farmer's perspective is a silver bullet, and it helps them, it do the job, which is fine, but like communication, education may need to be in place, and it's happening like a lot in Southeast Asia, so yeah. Long way to go, but something is starting there.
Thank you. So similar thoughts. I will just say for our context, a piece of work that we are getting into is advocating to members of parliament. So having them as champions of AMR. So we're advocating at the level of getting increased financing for antimicrobial resistance, for our response to it in country. And as he said as well, education is extremely important. So for farmers, they see it, the use of antimicrobials, as a way to, increase their profits. So we're talking about lives and livelihoods. So if you are taking that away and telling them, okay, leave this because it's increasing antimicrobial resistance, what's the alternative that we're providing for them? What are we helping them see that you can use? Are there vaccines available so that they're protecting their livestock instead of depending on antimicrobials and misusing it? So another thing that's important is ensuring that the policymakers understand. So are we telling them about AMR in a way that they understand? Are we giving them numbers? Sometimes using the numbers helps them understand. Speaking their language helps them understand the extent of the issue. So we're not just going at them with the public health data, but how can we speak their language? And a piece of work we did last year was convening stakeholders across the One Health sector to say, okay, who are the key policymakers that we need to explain antimicrobial resistance to, and what is the way they will understand it? So we developed a strategy for AMR data surveillance sharing. So we have the key stakeholders listed, how often do they need to be briefed about AMR, and what is the way that they will best understand what AMR is, so that they, as the key political decision makers, are equipped with what they need to prevent AMR. Thank you.
Thank you so much. More questions? Observations? Yeah, of course.
Não sei como em Tailândia, em Nigéria. Em Brasil temos um parlamento com 513 deputados, por exemplo. E existem no parlamento brasileiro bancadas, grupos, agrupamentos que são muito poderosos e fortes. E esses dois que foram citados por vocês são dois grupos muito poderosos no parlamento brasileiro. O chama Bancada Ruralista dos grandes agricultores, que contribui muito com essa resistência microbiana, e a outra dos laboratórios farmacêuticos. E isso é um grande desafio mundial. No Brasil, qualquer ação de uma só saúde, de reconhecimento, encontra barreiras gigantescas. A própria Covid foi... O Brasil foi um dos últimos países a iniciar o processo de vacinação, porque tinha uma resistência E naquele momento também era do governo principal, do executivo e do parlamento. Então, isso acho que é um desafio que não é só de cada país, mas é um desafio global também.
Thank you so much. I know our must-end sign has come. I don't know if we have any wriggle room left, but I think not. So just to say, really thank you so much to all of you for, arming us with so much more knowledge to take forward back to our own countries and, examples to cite so that One Health becomes policy and people know to act. Thank you very much for your work. Thank you for attending.